Good evening, everyone, and welcome to another session in our 2025 Better Billing webinar series, MBS with Billing and Advanced Care Planning. My name's Helene. I'm a Workforce Development Officer at Westvic PHN, and alongside me is Jade, who will both be working the webinar this evening. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings. They're freely on our PHN Learn YouTube channel, and the link to that is in the chat. And also our upcoming events are on the screen, and you can register for our events via the website, and that link is also in the chat. Just our main event for 2025, our primary care conference, and registrations are open and filling up quite quickly. So that's at the Good Sheds in Ballarat on the 10th and 11th of October. So you can have a look at the program and register via our website, and the link is in the chat for that. A reminder about our Health Pathways, which is a free online resource with local clinical and referral information for health practitioners. And the certificate of attendance will be emailed to you all. Please take a moment to check that your full name is displayed accurately on the screen. If not, or you're not sure, just rename yourself or type your first and last name in the chat box. This will make sure that we get your certificate to you. The event is being recorded, so please keep yourself on mute throughout the presentation and put your questions in the chat box. Because of the large amount of people in the audience this evening, the questions will be addressed at the conclusion. Your feedback is important, so if you could take the time to complete the event survey after the webinar, there's a link to that in the chat for you to complete. And I'd like to introduce our presenters for this evening. They are Dr. Ashley Van Leeuwenstein from Better Billing, and we have Suzanne Burette from Bowen Health. I will hand over to Suzanne now, who will commence the presentation. Thanks, Suzanne.
Thanks very much for the introduction, and thank you everybody for being here this evening. Just bear with us. We'll just get this show started. So my role is I'm a nurse at Bowen Health, and I'm involved in the Advanced Care Planning program. You may be aware there's been some significant changes recently, but we are still a program and still able to assist with some patients. And I guess for me, the key is about person-centered care and communication when talking about this. So I hope that you're all familiar with advanced care planning, and I guess this is about talking of the process of advanced care planning, where we help the person identify their values and preferences and document them, and also identify who they wish to speak on their behalf if there's a time, temporarily or permanently, when they can't. So really important documents. A lot of people don't want to do them, but we encourage them to. So I'm sure you're all familiar with the principles of advanced care planning, and I guess essentially it comes down to being a shared decision-making process where we get the opportunity to talk with them and to help them understand what would be appropriate or beneficial for themselves in different situations. Again, about the benefits, I'd just like to talk briefly about a gentleman that I met in the elective surgery unit prior to his high-risk surgery. He and his wife attended and had a really in-depth conversation, and he was very clear about his values and how he likes to live his life. A farmer, very active in his late 70s, very clear about what's unacceptable. Unfortunately, there were complexities with his surgery and it didn't go well, and the feedback to us was that his family, his wife and children really appreciated having such a good understanding of what was important to him. The health professionals, the medical team making decisions with the family. Really appreciated having a very clearly documented guide for them. And we all know that the hospital system benefits from not offering care or providing care that's inappropriate to what a person would want at that time in their life. So benefits to everybody. Again, I'm sure you're all very deeply familiar with the many triggers, and that you could probably put a face and a name to every one of these points in time where somebody might be newly diagnosed with an acute or a chronic illness, or somebody is deeply down the pathway of their deterioration. So these are time points where we would suggest the conversation about advanced care planning would be really important. Again, just a bit of a graphic to show that obviously for some people there isn't an appropriate time in the event of sudden death or deterioration. And then there are those who decline rapidly, and again, it might not have been appropriate to have been able to commence this conversation. But these are the ones that you would be most familiar with and that we really hope have the opportunity. Ooh, thank you. Where there is that opportunity at multiple time points to be able to come in and start, because again, we know that it's a process for many people, repeat conversations. So again, thinking of the chronic illnesses, significant change in their health, or if there's a diagnosis, a new diagnosis of dementia, for example, aging and frailty. We know that falls are a really high risk for people and are indicators of their aging. So the opportunity to use those health assessment time points. I'm now going to pass to Ash, and she's going to speak more about the billing process.
Good evening, everyone. Many of you have been to my Better Billing webinars here with the PHN. So my name is Ash. I'm a GP based in New South Wales and the owner of Better Billing, which is an online MBS education platform that mostly focuses on webinars and online courses and individual practice support. So tonight I'm going to run through a little bit of what it looks like in the billing space around patients that we see in general practice, and how this might look for you and for a group of patients that we see. So as with most of my presentations, I always start with a case, and this is Mick and Maureen. And Mick and Maureen are very much a falsified couple, but we all know a Mick and Maureen that we see. And Mick is a 78-year-old man. He has severe COPD, been taking care of him for about 5 years since they moved to the area, and he's had 2 recent hospitalizations this year, with getting essentially more and more hospitalized with his COPD. Recently has started home oxygen therapy since his last admission. And his wife, Maureen, is 74 years old. She had breast cancer 10 years ago. She's a type 2 diabetic, but is very well controlled. And she's starting to have to help Mick a lot more in the home. And so they're a couple that you see as a GP. And so what ends up happening here in Mick's particular case is that you end up sort of seeing him around December 2023, because he ends up having his care plan done with you. So a regular 965 care plan that's been completed with the nurse, the GP, or a combination of both. And then it gets initiated that he actually requires his over 75 health assessment. He's never had one, or it's been long overdue. And so he has his over 75 health assessment in the following month, in January 2024. At this point is when our nursing staff bring up the idea that, hey, Mick, things have, you become a little bit unwell, but also as we're becoming older, we talk about what we want in advanced care planning, and they might discuss around values, or they might discuss around what the paperwork looks like and how to bring it up with their GP, whatever that might be. And in that appointment, we discuss with Mick about what his advanced care plan is, and both Mick and Maureen end up coming back to us with their information. Then at the end of the year, in December 2024, Mick has another admission. And then what happens in this admission is he's now considered end-stage COPD. You've received a discharge summary back to you as the GP and says GP to follow up on patient requirements for end-stage COPD. So then what ends up happening is we end up seeing our patient Mick in January, straight after Christmas. He's been sent home. He knows his end stage. He's been linked in with the palliative care team in the community, which is great. But he's come to see you, and wants to really have a good in-depth conversation. And so this is where we touch base on what the level E consult looks like. So we'll go through this in more clear information, but just so that we can get a little bit about what the story looks like for Mick. Then we discuss around, okay, let's talk about symptom control. There might be discussions around things such as constipation, pain. There may be conversations about what home care looks like for Maureen, what supports they might need. And then you decide at one point you're going to get your nursing team involved, and they're going to be able to assist you with other sorts of follow-up through the use of 10997, which we'll discuss. So you decide in 1 week's time that you end up having a phone call with Mick just to see how he's settling. You want to check on how he's going with his breathlessness and his pain. And both yourself and the nurse are involved in that conversation. So your nurse may be able to provide some symptom control questionnaires and then provide it to you at a later point to have your discussion with Mick, or there may be further discussions around helping with home-based care, social work interaction, etc. Then you decide that you're going to see Mick 2 weeks later for his care plan. His care plan's due anyway, so he's going to see the nurse and yourself for his care plan. And there's been a clear change of circumstances, so that's another reason why we're thinking in this case that another care plan may be warranted, because in this case we've had a change of circumstances where he's now become end-stage COPD. It's decided then at the 1 week after the care plan mark. At the 3 week mark, we decide we're going to have a conversation again with Mick and his nursing and your nursing staff. And that might be, again, around symptom control. It might be around support for his wife, etc. So let's have a look at what this actually looks like. So what you can see here is we've got our timeline. So this is the timeline of what I've just sort of discussed around Mick's presentation and what it looks like. So early on in this piece, Mick ends up seeing you for his 965 or his care plan. And he does have quite severe COPD. He's not end stage at this point. Then his health assessment happens where his advanced care plan is discussed. And then his hospital admission happens here in this timeline. Mick follows up with you for his level E. Then he sees both your nurse and yourself in a telehealth environment. He ends up coming in for his 967 review, which is the care plan review, and then has another further follow-up on telehealth, including both the nurse and yourself. So what numbers am I actually talking about? And the numbers that I'm talking about here, that we're going to go through tonight, is 965, or the new chronic disease management care plan, known as the GP CCMP. The 707, or the health assessment item. In this case, Mick is over 75, so he's able to be having his health assessments done. Then we're going to talk about level E, which is the number 1, 2, 3, and what requirements that sits with. Then we're also having a look at the telehealth item numbers 91891, which most of us use quite readily. And then we're talking about telehealth item numbers 93203, which is where your nurse is actually initiating care for a patient who has a chronic condition. As such, this is the telephone equivalent of a 10997. Then we see that Mick comes in for his review, which is 967, and the nurse initiates further action, whether that might be around immunisation, that might be around symptom review, that might be around helping coordinate services. And then again, we look at another telehealth item number 91900. So we'll have a look at those a little bit more specifically around billing and what you need to do to be able to bill these item numbers. So let's discuss 965, 967. So these are item numbers that have recently changed. So since July, our care plans turned on their head and we were given a whole new set of numbers with new, somewhat new recommendations from Medicare of how they'd like to do it. So let's talk about 965, which is the preparation of the plan. And there is a face-to-face or telehealth item. And telehealth is video in this case, so this is not a phone number. So this is for patients who have a chronic or terminal condition that is going to last longer than 6 months or has already lasted for 6 months. The patients, in terms of Medicare's requirements to complete a 965, there needs to be a written care plan with shared goals and patient actions. So there needs to be discussion about what they may want. And in mixed case it might be around having home-based palliative care for as long as possible. And their plan, their action might be coming and seeing GP, initiating and continuing to work with palliative care in the community, what their planned services are there any multidisciplinary referrals, do we need occupational therapy involved, what might that look like? And then, of course, documenting your consent, offering the copy and making sure the plan is added into your records. So this is something that can be done every 12 months or earlier if exceptional circumstances. However, since these changes have happened, Medicare is really encouraging us to complete reviews rather than creating new item numbers every 12 months because financially they're the exact same. So we're being able to it's the same billable amount. So be wary that we mostly want to focus on reviews for our long-term chronic patients and not every 12 months reappear with another 965. So if we have a look at our 967, this is about our review, and this is where we are reviewing and updating an existing plan. So it's looking at the goals that we made. Have we had any allied health input? How are we going with palliative care? How are we going with our symptom control? Is staying at home still an option? And where are we at with our goals? Then in terms of frequency, this can be done every 3 months or earlier if an exceptional circumstances come about. Please note at the bottom about the requirements for care plans at this point. So the patient must either be registered with your practice under My Medicare, or if they refuse or they're not interested in being registered with My Medicare, then it can be done with their usual GP. You cannot co-claim with standard attendance items. That's been even more specified this year by Medicare, which previously they never did. So your 23s, 36, 44, be prepared that you cannot actually be billing those item numbers at the same time unless there is an exceptional circumstance. And this consult item number itself is actually a GP item number. So the nurse may assist, but the creation of the care plan or the reviewing of care plans are not able to be attracting a 10997 billing. So then just quickly on health assessments, which is the over 75 health assessment, that's for patients who are not in hospital or residential aged care. In that case, it's Mick because he's not in hospital at that time. And you can see here on the sides what the reason for the assessment is, mostly an overall health of physical, psychological, and social function. There is mandatory components for your health assessment for the over 75s as per Medicare. So as you can see here, baseline observations, medication review, continence, immunization status, physical function, psychological function, and social function need to be minimum requirements that are completed in an over 75 health assessment. These can be done every 12 months. And as you can see on the right-hand side, these are time-based. So if, for instance, you don't spend 60 minutes with the patient, you might end up spending 40 minutes with the patient, then a 703 would apply. But however, the requirements still need to be done no matter how long you spend on it. Your billing code will represent your time, not the actual assessment that's been completed. So let's talk about level E, which is item number 123. Now, this is a new item number. It's relatively new, and it's an item number for a GP consultation of at least 60 minutes of personal attendance with the patient. So the patient is with you as the GP for 60 minutes. So this is a general attendance item number. So this could be extensive history, this could be examination, investigations, preventative healthcare, management plan. Whatever your role might be, this is able to be used for a wide variety of reasons, as it is under general attendance. However, the patient needs to be present the entire time. So the patient can't have left after 30 minutes and you have 30 minutes left of paperwork. The patient needs to be in the room with you for 60 whole minutes. You cannot spend you cannot count time spent with another practitioner, namely a nurse. So the patient kind of spent 40 minutes with the nurse completing some other task, and then you claiming 20 minutes of your time to a level E. It needs to be 60 minutes of general practice time. All clinically relevant tasks during that time may be included, but the patient has to be present once again. So then let's have a look at the telehealth item number that I popped in there, which was 91900. Now, this is a table that is available on my site under the resources. It's a full Medicare cheat sheet, all of the codes, all of the current fees that will attract and what they look like. And you can see here that one of Mick's telehealth item numbers was 91900. And that is where we've essentially got a level C, 20 to 39 minutes, which is an equivalent for your 36 on the phone. Now, this specific item number comes with some clear guidance from Medicare, and that's about having the patient be registered with the billing practice under My Medicare. So the patient can only access this number if they are registered to you through My Medicare. And this is another general attendance item number, so general any sort of history taking, investigation, or management plan can be completed during that time. However, if your patient is not registered under My Medicare for this, you will not be able to bill this item number. So nurse support numbers. So these are the specific numbers that I wanted to talk about tonight. So the first one, the one I will be focusing on is 10997, which is the services by a nurse to complete for a patient with a care plan. You can see there's a video and a phone item number. A lot of people actually don't know that there are video and phone item numbers for nurse support. They believe it's only face-to-face, but that is definitely not the case. And in this case with Mick, I've had him included with 2 particular phone call follow-ups with the nurse, which can be billed by the GP when they complete their general attendance on the day. So let's have a look at what 10997 is. So what can my nursing staff be doing with 10997? And there's a whole range specifically to general practice. So it's not about creating or reviewing the care plan. It's about the actions that nurses do for our patients every single day that help them with their chronic disease. And in this particular case, that might be observations, that might be helping a patient administer insulin or teaching them about it. It might be mood monitoring. It may be talking about advanced care planning in a patient that you wish to have that discussed in the next 12 months. It might be about depot injections for those with schizophrenia, influenza vaccinations for children with asthma. The list goes on. And in this particular case, just note that the goal or the information of what your nurse is doing needs to actually be within your CCMP in the goals or the task created in the care plan. So if your patient has osteoporosis and you mention that they need to have their 6-monthly Prolia injection done and your nursing staff is going to be the one to help facilitate that, you need to mention that in the care plan so that that can be claimed through your 10997 number. So, and then just a little mention on JPACI, and this is about what if Mick was actually in aged care. And JPACI is about focusing on what My Medicare does in terms of incentive payments. So for those of us working in aged care, they are quarterly incentive payments that are given to us for our services to patients that are registered to us in both JPACI, which is General Practice in Aged Care Incentive, and also My Medicare themselves. So eligible GPs and practices receive incentive payments for providing services to their registered patients in a residential aged care home rather than at their practice. Payments are around 300 per patient per year to the GP and 130 to the patient per patient to the practice. So have a look online. I haven't mentioned anything else too specifically in terms of what the criteria is, but there are specific criteria of how many times you need to have seen your patient to fit this incentive. But another thing to mention that if Mick was to go into aged care and that was something that you took over, he would be another person that you would be thinking about JPACI and My Medicare for. I will send it back over to Suzanne.
Thanks very much, Ash. So there's so many time points that these conversations can happen and are likely happening. And I guess the critical point of it is gathering all of the knowledge that you've got about this person and documenting it down. So whether that's the nurse, whether that's the doctor, these multidisciplinary conversations are really helpful because it helps the person to understand this is actually really important and we do actually really value what you have to tell us about yourself. And you'll find your own way of having the conversations. No doubt you're already doing it as part of your practices. Really, this is just a way of formalizing the many things that you've learned and gathered about the person as you've met them over time. And it can be a really simple thing to do, to simply say, Mick, how you going? I saw from your discharge summary you've had a time in hospital. How are you feeling about it? So using those open questions, you might not even want to start off by using the term advanced care directive. We often get people saying, asking if we can help them with my aged care or can I organise the cleaner. The language really matters and the terms we use can be a bit off-putting. So we can do an advanced care directive without even necessarily using those terms. So ask them what's going on and then they'll probably tell you everything you need to know without that many questions. It's really helpful to think of it in this flow. If something happens to you, who do you trust to speak on your behalf? And when they tell you that, that's automatically that appointment of medical treatment decision maker. And there's some things that are important to guide them about. It has to be somebody that's accessible to the hospital staff. It has to be somebody who can or is willing to stand and step up for you. And it has to be somebody you trust to reflect your preferences and values and not what they might wish for you. And it has to be somebody who was able to take on the role of dealing with somebody in a senior position like a hospital doctor. So once you know that person, you can fill out that appointment of medical treatment decision maker. And then their values, preferences and beliefs, that's what we call a values directive. People say, I never want to go into aged care. They might say, look, I don't want to be a vegetable. We really tend to discourage the use of that term because it really doesn't mean a lot. So we try to be far more specific. It's important for them to be able to go out into their garden. We want to find out what's important in their life. Not everybody wants to do an instructional directive, which is where there are specific treatment limitations involved, and they don't have to do that. But that opportunity in the advanced care directive is there if they want that. So again, this conversation is happening at multiple time points with perhaps different people. And we'll talk more about how you document and what things are important to include in that. But at the end of that conversation you've had with them, it's really important to let them know what they've told you is important to the healthcare professionals and that, yes, it is important to their family. And can we document that with you? Because they might feel quite reluctant to talk about documenting it, whereas they've been really happy to have a conversation with you about it. So again, you've all got your own styles. You're doing this already across your practices. But thinking back to the trigger time points, particularly for Mick, it's that discharge summary and it's his next appointment. It's introducing the opportunity and saying that we can set up another appointment to talk further about it. I see that you've been unwell and it's really important that we get your sense of what is appropriate for us to do in future if there comes a time that you can't tell us yourself. Finding out who he wants to speak on his behalf. Most commonly it is their partner. But as you know, families are complicated. And for many people, they want to make sure they know who can speak for them. And that's where, even if they don't do an advanced care directive, they can do a medical treatment decision maker. That gives them the confidence. And some people are really confronted by the idea of doing an advanced care directive. So we try and say to them, this isn't for now. Anytime you can sit and talk for yourself, that's the conversation you have with your medical team. This is for if something happens later. So we plan for the best or hope for the best, but we need to cover off if things don't go so well. This is a great little video just to give you some examples. So let's go ahead and and watch this. Helene, if you're there, am I...
There we go, you can have your finger back now.
Thanks.
Michael, it's really good that all your tests are stable, your CAT score's stable, or your blood tests are stable. It's really good to see that you're looking after yourself. Michael is visiting the practice today to review his chronic disease management plan. After my initial assessment, I checked with him to see if there were any other concerns. At these appointments, aside from checking out what's happening with your body, we also like to give you the opportunity to tell us what's concerning you so we can help with that. So is there anything concerning you?
I must have been a little worried about what happens if something at home happens. What does she do? Ring an ambulance? I don't know if I really want that. I would like to stay away from hospitals as long as I can. But then, if I get seriously ill, is it going to be too much for her?
I can understand why you'd be concerned about that. Some things we can do. We can put you in touch with some community services, some palliative care or some home nursing services that might be able to help you at home.
No, I don't think we need that yet. No.
I can understand that. But what about if you did fall? What would happen?
I don't know.
Something you could be thinking about now would be someone who could speak on your behalf if you couldn't speak for yourself.
Well, wouldn't they just ask me?
Yeah, they probably would. But you need to know what's important to Michael, what sorts of decisions you'd be making on his behalf.
We've talked about that.
That's really fantastic. So Sherry would know what you'd want if you did collapse and if you did need to go to hospital?
Well, we haven't really talked in that detail yet because, I mean, we don't know what's going to happen.
Yeah, it's hard to know what's happening in the future. None of us have got a crystal ball. Mine's broken. It is important to have a chat about that. It's important for us to know what you would want so we could act on your behalf.
Right.
So there's a 5-step process involved with this. You've already obviously started the process. You're thinking about it. And that's the first step. The next step is to talk with someone about it. You've started talking with Cherry. Yeah. That's really great. The next part of the process would be to formally appoint that decision maker, someone who could speak on your behalf if you couldn't speak for yourself, someone who's confident, who knows what you would want. Mm-hmm. Yeah. The next part of the process is to write it down, writing down what your wishes would be if you couldn't speak for yourself, so we can all work off that same page, and then sharing it with the healthcare team. So with the hospitals, with anyone else who's caring for you. It's not written in concrete, it can change as things change for you at home, as your health changes. So what we can do for you today is to give you some information to take away, maybe a form to fill in. You can think about it and have a chat with each other. I can record it in your notes so that you can bring it up with the doctor next time you're here. Would that be okay?
Yeah, no, that sounds good.
Yeah, that'd be great.
Does sound good.
All right. So hopefully that's given you some suggestions, some language, and just an overview of the way that this is introduced and then the conversation carries on. But it's got them thinking, hasn't it? You can see that. And I think they look quite receptive to the conversation. You're all aware of the documents that are available, but there's another one I just wanted to point out, which is the appointment of a support person. We'll speak a little bit more towards that, but that's another one of the suite of documents that's available to help people when they're having these medical conversations. And it's somebody legally appointed to assist them now. It's not after they no longer have capacity for themselves, but it's to support them as they go through the healthcare system, have medical appointments, make arrangements. And it might be somebody that is able to communicate with them in at a different level of health literacy, for all different reasons. So the appointment of a support person, you might not see the need for that in the practice, but it becomes really important when they arrive into the hospital because it gives that support person the ability to be really engaged in whatever's happening. And I'll also talk to the values and preferences document a little bit down the track as well. That's available if somebody no longer has capacity to make a legal document, that is still available for the family. Just one point to bear in the back of your mind, if somebody is really reluctant to have this conversation, that's okay, they don't have to. This is not a compulsory activity, but it does help to remind them that if they are in a family with complexity and they can't think of anybody who they would identify as a decision maker, there may need to be application for VCAT for guardianship and administration down the track if things got complicated. So if we can get them thinking and identifying somebody earlier, it can often cause a great deal of difficulty down the track. And just a reminder that these are the titles of the current documents, but if they've previously done something called a statement of choice, that used to be what we did as an advanced care directive, or if they've appointed a medical power of attorney, those documents remain legally valid. They don't have to be updated unless the person decides they'd like to make some changes. So to recap about the medical treatment decision maker, mentioned before that appointed by the person, somebody that they trust and can act on their behalf. There is a formal hierarchy. If somebody's not willing to appoint a medical treatment decision maker, we refer to the identified hierarchy, and that is the first person is the VCAT appointed guardian, the second defaults to the spouse or partner, the third to the primary carer. That's not a paid carer role, that's that informal person caring for them. And then it defaults to the adult child by birth order or parent if there's no children, and then siblings. Now, this is all in the setting of somebody who has a close and sustained relationship with the person. So it often nieces and nephews might be involved. They might say to us, oh, look, I've got a nephew who's involved. I've got a niece who takes me to appointments. They are not in this identified hierarchy of decision maker. So if that's somebody that person wants to have involved in future, we really want to encourage them to formally appoint them. Otherwise, it becomes the Office of Public Advocate. So I want to just show you some examples of advanced care directives, of the value statements that we often see coming through. And I just want to give some pointers about the kinds of things that are helpful to write into this. Language is really important. And yes, everybody says, I don't want to be a vegetable. So it's our role to facilitate the deeper conversation about that. We need to be more specific. I still recall Charlie Cork from intensive care as he's guiding us through this saying, you know, what does a vegetable mean? And we need to get a clear idea of how that person prefers to live their life. And is aged care acceptable, for example? And that is quite a common line in the sand for people. You know, I'll stay at home. I'm willing to accept care in my home. I'm willing to accept that my life becomes lesser, that I can't do as much for myself, but I want to stay in home. And then it's our job to sort of talk about high level care, low level care, what happens if you no longer can. And that's the point where they might start to decide to do an instructional directive. My home is that important to me that I would willingly sacrifice other things to stay there. These preferences and values are great, and I encourage people to think of it as a love letter to your family. What's been wonderful? What do you enjoy in your life? What is it that you would rather give up or sacrifice? So, you know, that's a helpful term, that idea of it being a love letter to the family, because it helps reassure them that they're communicating really important information. I think it becomes really important to think about then that instructional section. And we see a lot of value statements written in here. And I'd really remind everybody that instructional directives need to be very specific and very situational. So often we might get somebody saying, I consent to CPR if I'm going to be good, if I'm going to be able to live a life and have quality. That's not an instructional statement, that's a value statement. So it doesn't belong in this section of the Advanced Care Directive. That's the kind of thing we'd write in that section, other things I would like known, for example. These statements need to be really clear. So looking at the refusal section there, that's a no to cardiopulmonary resuscitation or defibrillation. Reminding the person that this document only applies if they are that unwell they can't speak for themselves, or if something significant has happened and they no longer have capacity, temporarily or permanently. So if they want to add a rider to that saying, you know, I don't want CPR if I'm not going to end up very well, again, that goes back to being a value statement. Intensive care, including intubation and ventilation, might be quite an appropriate thing for somebody like Mick to say, because we know he's got end-stage pulmonary disease. It's not going to get better with a trial of ventilation, and in fact, you know, is likely to get worse. So we have to be really clear when guiding them about when to write an instructional directive. It may be quite appropriate. He just may not be willing or able to do so at that time. So we would still write a really good values directive with a lot of information about what he would consider to be unacceptable. But we may see a person who said, look, no, I'm clear about that. I don't want that distress for myself or for my family. So in that situation, perhaps it's metastatic cancer or end-stage lung disease or heart failure. Yes, it's quite appropriate to be very specific. And then I always reassure them, just because you're saying no to those high-level interventions doesn't mean we're not going to do anything. If you fall and break your wrist in the garden, come on in. They'll fix it and send you home or where you're happy to be. If you get a skin tear, an infection, come on in and we'll give treatment for that, for those reversible illnesses or injuries where they can regain the level of function that meets their need. So I want you to just remember, when you're doing that instructional, it is that shared decision-making process. They need to be guided by you about what's appropriate in some instances, but it remains their directive. So with that shared decision-making, just another brief thing is, often a lot of people say, no, give me everything, I want everything. And that's okay, they can want that. But it's quite helpful for you to be able to, talk with them about what their disease trajectory is, because if they don't have that insight themselves, you're the best starting point to have that conversation with them or continue the conversation. But the second thing to talk with them about is, there may come a time, or there will likely be a time, where what is on offer is no longer beneficial for you, and it's not going to be able to return you to the living situation that you've already told us is really important. And to help their family to understand as well that doctors won't necessarily offer things that aren't going to be beneficial. So it may be something that you want, but be aware there may come a time when it's no longer on offer. And that can be an important conversation to have with them. Just coming back briefly to that appointment of a support person. So we've covered off medical treatment decision maker. We've covered off a values directive, and then expanding that to instructional directive if it's appropriate for that person. And now the appointment of a support person. Again, they may have language, communication, learning difficulties, healthcare literacy, but somebody who can be with them and who the health staff will engage with about what that person needs while they have capacity. We don't have to wait until they don't have capacity for this document. So speaking of not having capacity, it's a shame if we've missed the boat, but that happens for a whole raft of reasons. And maybe the person just was never going to be ready to either want the conversation about an advanced care planning or to want to document it. So in this situation, if as the medical practitioner who would be having to sign an advanced care directive stating they've got mental capacity, if you don't feel that that's the case any longer, you could still offer the person this document. It's a terrible title, Values and Preferences Statement for a person who no longer has decision-making capacity. And this is where family, friends, carers, people who know them over time are able to add the information they have, so that particularly if they were to come in for an admission to the hospital staff would be aware that they get really distressed in loud, bright environments, or they really don't like to be lying flat. They much prefer to be in a semi-upright position. All of those physical things, but also some of that emotional knowledge that they have that's helpful to communicate. And it's the start of the conversation with the medical team about life-prolonging or life-saving interventions. So a really useful document, even though it's not signed legally by the person at the time. So that note about decision making, you're already making these assessments on the daily basis. Just to recap though, it's not global capacity. This is decision-making capacity as it relates to an advanced care directive or appointment of a medical treatment decision maker. Can they understand it if we've provided the information in a way that's comprehensible for them? Can they retain it just to the point necessary to be able to communicate it back? And can they make a decision and understand the implications of that? So it's something that you're doing all of the time already, but we also need to be aware that we should do it in an environment that's conducive for them. So if they tend to be better in the morning, that's when we want to have these conversations with them. I just want to touch briefly on a lot of the common errors that we see coming back in documents from clinics. It's not uncommon for the person or the doctor to have not signed. Obviously, this is a big process. There's a lot that you've already had to document, discuss, and it's the legal stuff at the back that tends to fall over. So please make sure that you sign. Please make sure the person signs. As far as witnessing, it cannot be anybody that's being appointed as their decision maker. So it's just easier to get a staff member in to do that second witness. Even if the family member is sitting there, I wouldn't ask them to do it in case they are that identified or appointed decision maker. Dates are often missing, particularly with a medical treatment decision maker document. Often family members might try and fill out the form beforehand and they'll date the document, their acceptance signature, before it's been signed by the person appointing them. Look, that's not a big thing, but technically it invalidates the document. So be aware of that. And if they have already filled it out, just get them to change the date on the signatures. But I guess the biggest thing that we often see, which makes the documents less useful at that pointy end by the ED doctors or the ICU doctors or the family, is where we haven't helped them be more specific about how they prefer to live, what quality of life means for them, what's unacceptable, what are they willing to give up, what would they be willing to sacrifice, and then being really specific in that instructional section of the Advanced Care Directive. So great that you're doing it, great that you're having the conversation, wonderful if you can even get the document signed, and even better if we can get a copy of that document back to Bowen Health so that it's there on file should they need to turn up to the emergency department. Thank you very much. Hopefully there's been some useful information there for you. these are some resources I'd encourage you to have a look at. The Advanced Care Planning Australia website, Department of Health Victoria, and the Office of Public Advocate have got some really handy resources there as well.
Could I just take the opportunity to thank both Suzanne and Ashley for tonight? Great event again. Thank you very much, Ashley, and thank you, Suzanne. Fantastic information. Good comments coming through now. I'll just end this webinar now. Thank you all for attending, and please fill your evaluation in. Bye, everyone.
Thank you.